Hi, good evening all. This is Dr. Ranjith. I'm the head of HOD Emergency Department, Yashoda Hospitals, Somajiguda. Today, we are going to learn how to manage arrhythmias in emergency room. So we have here our speaker, sir, Dr. Srinath Kumar T S. He's our group head for all the 4 units of Yashoda Emergency Department. He's also an academic council chair for SEMI, a treasurer for IFEM and ASEM, National Academic Coordinator for ANBAI, and Associate Editor for NJEM and EaJEM. We welcome you, sir. It's an honor to have your presence here for this talk. Sir, please handing over to you for the session.
Thank you. Thank you, Ranjit, for that kind introduction. Hello all. Good evening, everyone. Welcome to this topic as a regular series of Yashoda Hospitals. We present you the series on emergency medicine every Friday between 6 to 7. We welcome you for this today's topic on arrhythmia management. As Dr. Ranjit has informed you, it's a pleasure to speak to you all. If you have any questions, you can put in your chat box, so that we'll be able to look at it and start answering it at the end of the session. So always I keep telling in the emergency department, whenever we start a topic, we should have some objective for it. What is my objective today? It's about the arrhythmia management in emergency department. So before going into the arrhythmias, what you have to learn is the physiology, and then look into where from the arrhythmias can generate, and what are the types of arrhythmias which can happen, and how do you manage them. So these are the things which you are going to learn over the next 40 to 45 minutes, and then we will take the questions in the remaining session. So that's what we are going to give you the brief outline for today's topic. So why an arrhythmia is very important? Because if you see in emergency department, if you take 100 patients here coming into your emergency department, I'm sure that there will be 10% of your cases which are related to the cardiac issues. Can be a pulmonology, can be a stroke, can be anything, cardiac arrest or anything. But again, it lands down to what you're going to see, that is your arrhythmias. So they interrupt. Why the arrhythmias are important for us in the emergency department is they can interrupt the blood supply, they can interrupt the oxygen supply to the brain, and also it can interrupt everything, that is the oxygen transmission and the carbon dioxide. All these things have been interrupted. So to look into these things, we have to be very, very careful in emergency department. We have to monitor, we have to see and look, and then start the treatments accordingly. When a patient walks in, like I'll give you a simple example. The patient walked into the emergency department at around 9:10 a.m. saying that I have a chest pain. So we took the ECG, we saw everything, we did the tropo, everything was normal, very good, good enough that the emergency department has performed well. And then after 2 hours, he came back again and said that still my chest pain is continuing. And at that particular moment, before taking him to the stretcher itself, there was a problem that he went into the cardiac arrest. And when they checked for the central pulse was not there. And when they conducted to the monitor was showing ventricular fibrillation. You may ask me a question that why did you send this patient out? We didn't send the patient. The patient wanted to show to the cardiac OPD. So he went there, and then he came back with this. But luckily, he was within the hospital. A code blue was not, and we need not be announced because it happened in the emergency department itself. So the ventricular fibrillation was readily been monitored. It was been treated. The patient got the shock given. We started the patient on amiodarone, and then he walked back home 3 days later on to his house. So that is the magic of emergency department, and that is the magic of we looking into the patients for arrhythmias in the emergency department. And it is always a proud moment being an emergency physician. Whenever you see such patients walk back home, you feel more and more happy, and you feel more and more thrilled to see these patients, because we know, as I mentioned here, the patient can come in with asymptomatic, a patient can become unconscious, a patient can become into cardiac arrest, and then he can walk back home. So that is the way we emergency physicians always be proactive, look into them, treat them in the right way, and ensure that the patient's morbidity and the mortality has come down, and then they walk back. So with this a small bit of introduction, I will take you into the arrhythmias. And always the important thing is whenever you suspect a small little bit of change in the ECG also, it is better to take, if a monitor is showing some slight discrepancies or some kind of an untoward incidents, you see the ECGs, then you have to pick up with the 12 lead ECG. That's the very, very important thing. And when you're looking into the ECG strip, please note the speed of the strip, the 12 lead ECG, and ensure that the lead 2 is taken in the long strip so that you can compare and treat the patient. This is very important again because you look into the 5 things which you're looking into the ECG. The first is whether you're seeing the P wave, Q wave, R wave, S wave, T wave. So all the waves should be seen. And then what else you have to see? You have to look into the PR interval. Look into the PR interval. What is a normal PR interval? All those things I'll be seeing. I'll be letting you know in my later slides. Look for the PR interval, then look for the QRS complexes, then look for the ST, and then RR intervals, whether it is regular, irregular, regularly irregular, or irregularly irregular. So these are the things which we have to keep in our mind in the emergency department when we are looking into the ECG, which will give you a comprehensive thing which you want in the emergency department. That is how an emergency physician, we all should be looking into and treat the patients accordingly. So this whole graphics which you are seeing, I am very, very thankful to my colleague, Dr. Naveen Nimmala, who is always helpful. He has given this graphic design, which you are seeing here, and it will be making you very, very easy to follow up and say that, okay, this is what I'm going to see when I see an ECG. When I see a P wave, where it has been generated. When I see a QRS complexes, where it has been generated. When I see an ST wave, where it is generated. Because these are the things which we have to keep in our mind in the emergency department. Now you may ask me, where will the P wave be generated? It is always because of the atrial depolarization. When there is an atrial depolarization, the SA node will start giving a stimulation where you can see the P wave, followed by you see a dip, and again the QRS complexes start. So where does the QRS complex start? It is because of the ventricular depolarization. So you see the QRS complex, the Q wave, then going up, R wave, then coming down is the S wave. So QRS complex is been because of the ventricular depolarization. Then you can see the T wave, which is because of the ventricular repolarization. So these are the 3 things which you have to keep in your mind, and then accordingly you can also say that which arrhythmia has been caused because of this. Whether if it is because of P wave, it is because of the atrium. If it is because of QRS complex, it is because of the ventricles. So this makes simplified way to you to understand the basic principle of an arrhythmia. Now the next important point is, you can see there are a lot of waves here. For us, the most important thing is your SA node, AV node, bundle of his, and the Purkinje fibers. These are the 4 important things which we have to keep in our mind, because the stimulus which has been created in one of these things will cause the arrhythmias when there is a little bit of a problems in this nodes. Now, how much is the heart rate you and I have? That is between 70 to 90. This is being shown because of the SA node. Whenever the SA node is there, the heartbeat is between 80 to 90 beats. That is the prime one. So when the SA node is not taking over, or there is a stimulus which is not coming, then the AV node will buck up. It will give up to 60 beats per minute. So then the bundle of his, that is 50 beats per minute, and then the Purkinje fibers, that is less than 40 beats per minute. So you can analyze now and see that where is your regular rhythms which is coming in, and what am I looking to seeing it. The fastest pacemaker always controls the heart rate. Now, if the Purkinje fibers are stimulating more than 80, then that will take over, and that is what you are seeing in the monitor or the ECG rhythm, which will be reciprocated where it is being generated. That is why you are seeing that it is bucking up and it is giving the rhythms more than the SA node. That is why you see only those Purkinje fibers which is looking in for. If the AV node is creating more stimulus or heartbeats, that means that you are seeing the SA node ones, that is a stimulus. So this is how a pacemaker is is within the normal human being which is taking place, and whenever there is an abnormal thing, that is what is giving the stimulus, and you are looking in as an ECG or an or even in a monitor what you are seeing. And the slower the pacemaker takes over when the fastest is not acting. That means that if the SA node is not acting, then the AV node will take over. If the AV node is not acting, then the bundle office is taking over. If the bundle office is not taking, then the last and final option is your Purkinje fibers. So this particular principle, if you keep in your mind, then you will understand the ECG very well, and you can analyze an ECG at a better pace, and you will never forget an ECG. Whenever you see an ECG, if you mention in this format about P wave, about QRS complex, about ST elevation, and about the RR interval, and finally you mention whether it is normal sinus rhythm or arrhythmias or anything, then you will never forget in your lifetime. Because if you forget to write all these things, after 1 month, whatever I have told you, if you get a fresh ECG and see, then again it will be like a ABCD for you. So that is the reason why every emergency physician, every emergency resident has to take care of this and keep in your mind about this simple logic thing. Now, what are the fundamental descriptive properties of a cardiac rhythm? There are 3 fundamental aspects of every cardiac rhythm. So what is this 3 things which happens? One is your anatomical origin, second is your discharge sequence, and last one is your conducting sequence, which I mentioned you. So if you see the anatomical origin, that is your SA node, AV node, Purkinje fibers. Now the discharge sequence is SA node, AV node, bundle office, Purkinje fibers. That is how the conducting system sequence is also taking place. And that the whole thing which brings in you is the descriptive properties of a cardiac rhythm. So these 3 things fundamentally you have to keep in your mind when you're looking in for. So to tell you more, whenever there is a discharge sequence, when it is normal, when you see everything in a normal way, the heart rate is less than 90, the P waves are seen, the PR intervals are normal, QRS complexes are normal, ST elevation is not there, then the T wave formation is there, that is normal sinus rhythm. Now you may ask me, what is the PR interval? What is the QRS interval? The normal PRS interval is between 0.08 to 0.12. Above this is always, there is a PR lag. That is what you have to keep in your mind. The QRS interval is 0.04 seconds to 0.08 seconds. So these are the 2 simple things you have to keep in your mind in the PRS interval, PR interval and the QRS complexes. So whenever the rate is high, that means that 90 or plus, that means that it is tachycardia. The discharge sequence is pumping more. That gives you the tachycardia. When the heart rate is less than 60 or less than 50, then it is bradycardia. Whenever there is a fibrillation, that means that the heart is just simulating just like a small fibrillations which come in. That is fibrillation. And flutters, you can see in the next this one, it causes the SA node and the AV node is not synchronizing properly, and then there you can see a flutter wave, double times the P waves are present, or double times the PR intervals are present. Then extrasystole, that means that before the next P wave is brought or before the next QRS complexes, you can see sometimes the early systolic complexes, that is you can see a QRS complex in between the next 2 RR interval. So that means that there is a extrasystole or parasystole. So this is what you have to keep in your mind about the discharge sequences. Now, what do you see in a conduction sequence? The conduction sequence is normal antegrade. That means that SA node, AV node, bundle office, and then the this one Purkinje fibers. That is normal antegrade conduction sequence. When this normal conduction sequence is left over, then there is an aberration. Whenever there is an aberration, then there is the arrhythmia is formed. If there is a SA node block, then again the heart rate is prolonged. That is how you can see the bradycardia, which you can see. Then the AV block, which can happen, or they can also be a reciprocal changes, which the conduction system can be looked in for and the sequence can be noted. So this is what you have to keep in your mind: anatomical, discharge, and the conduction. So these are the three important things which you have to keep in your mind and look in for. Now the pacemaker physiology. So electrophysiology of a pacemaker, if you see that phase 0, you see that the voltage starts increasing, and then that is a phase 0. Then there is a slow influx of the sodium via the funny sodium channel. And then the voltage gate is because of the T type, that is because of the calcium channel. So these three things are very important for a pacemaker electrophysiology, which you see as a wave which you're seeing up and down and again going up. Now, what is myocyte electrophysiology? This is what is important for you and me, where you see the sorry, phase 0, that is the opening of the voltage gated sodium channel. So that is when the sodium channel is opened up and you see the phase 0. Then the phase 1, just a tip is there. That is because of the potassium efflux, where the V gate is opened up. The potassium efflux starts in. And then your phase 2, that is your plateau. That is because of your calcium and potassium channels. So that plateau is seen because of the calcium and potassium channel. And lastly, the phase 3, that is the potassium efflux. So sodium channel, then potassium efflux, then calcium channels, then the potassium efflux. That is what is about the myocyte electrophysiology. Now, you see there, it is described in a much more when you keep both the myocyte as well as the SA node and the AV node. You bring in closer and see what exactly I said in my previous slide. You can see here that this is how the SA node and the AV node forms, and the electrophysiology which you are seeing is been formed, and you see, and then you can tell that this is what is happening in the ECG also. Whenever this particular waveform is been misled, then the arrhythmias are started. That is the way you have to keep in your mind. Why am I telling you all these things? Sodium, potassium, calcium, because all your anti-arrhythmic agents are based upon the action where this particular action comes in, whether it is because it is acting on the sodium channel or potassium channel or calcium channel. So these three channels where the anti-arrhythmic agents will react and regularize your arrhythms. This is kept in your mind to tell that this is how it has been acted upon. Now, what is the pathophysiology of arrhythmias? You saw the physiology, now you are going to look in for pathophysiology. There is an arrhythmia is because of increased automaticity of the SA node or AV node. So what did I say to you in the first slide? That is, SA node will produce 80 to 90. Sorry, AV node will produce a 60. So there is an increase in the output, then automatically the heart rate will increase. That is what is a problem. Now, what is the triggered activity? The next important thing, that is early after depolarization or long delayed after depolarization. Where can this happen? Early or delayed? It is because of hypoxia or sympathetic overdrive. So that is your trigger is there. Your hypoxia, whenever the oxygen levels come down, that means that there is a trigger. So that means that there is a trigger that the heart has to pump in more blood because it has to carry forward the oxygenation. It has to reduce the carbon dioxide. Otherwise, it keeps on triggering. That is the reason why you get early or a delayed depolarization. Again, when hypoxia is there or whenever there is a sympathetic overdrive, what it causes? Either again it will go, the adrenergic surge has happened, it will go and start simulating. It will stimulate all your sodium and potassium channels, and then your rapid fire starts up, and again this leads to an arrhythmia formation. So the second part is your triggering. First part I said you automaticity, which is increased upon. Second is triggers. The last one is re-entry circuit. That is because of the anatomical. The re-entry circuit is SA node, AV node, bundle of is Purkinje fibers. Again, it has to go back. Again, it has to come down. So whenever there is a problem with this re-entry circuit, then you can see that the arrhythmias formed. A typical example for this is whenever there is an anatomical problem, you see the WPW syndrome, or if it is functional, you can always see a ventricular tachycardia or AV nodal issues, AV nodal re-entry problems or the atrial fibrillations. So this is what you're going to see in your re-entry circuits which can happen. Lastly, eventually, what is the problem is it increases the action potential duration and decreases the effective refractory period. That means that what is the problem is before sometimes when you see the atrial fibrillation or ventricular tachycardia, before it comes back to the normal one, the next wave is formed. So that is the reason why you see there is a re-entry circuit problems. For us in emergency department, we see more of hypoxia, sympathetic overdrives, and functional issues, re-entries. That is the major problems which we see in the emergency department. And that is how you can analyze based on the pathophysiology. You saw the physiology elements, now you saw the pathophysiological element of the arrhythmias. So these things you have to keep in your mind. Now, there are multiple arrhythmias which you can see in. So to name a few, or you see the regular arrhythmias, what it is, whenever you see, I said you, and that is because of the atrial. So commonly what do you see? It is because of atrial fibrillation, atrial flutter, or supraventricular tachycardia. It is because appearing before itself. Supra means before the ventricles. That is in the AV node, between the AV node and the bundle office. There is continuous stimulation. So that is the reason why you have to monitor for these three whenever there is a P wave problem, atrial fibrillation or atrial flutter. Then you can watch for the supraventricular tachycardia. Now the next one, what I said was QRS complexes. QRS complexes is mainly ventricular, I told you. So that means that what are you going to expect here? That is commonly is your ventricular tachycardia, ventricular fibrillation. So these things you have to keep in your mind. The next important problem is your T waves. Where can the problems happen with T waves? It is commonly, as I mentioned, it is in the potassium channel. So you have to keep in your mind about the potassium whenever there is a problem in the T wave. So the P wave, QRS complex, and the T wave. So these three things you keep it in your mind, and then you can accordingly treat the patient, what drugs it has to be given and how it has to be given. To broadly classify, we have the Vaughan Williams classification of the drugs. The nature of the drugs is mainly dependent upon your sodium channel, potassium channel, and calcium channel. You saw the waves which I showed you. So now you will understand the mechanism of action of the sodium channel blockers, which is 1A, 1B, and 1C. In 1A, you are going to see the invert of the sodium blockage. What are the drugs which can cause adverse drug reactions? The Torsades point is drugs induced SLE or synchronism. So these are the three common adverse drug reactions which you can see. What are the name of the drugs? You can see with procainamide or diisopropionate or quinidine. So these are the common drugs which can cause or which can be seen as an adverse reaction. What is the things which you can use in for? Now, the second part is your 1B, that is block phase 2, 0. That is what you have to imagine what I showed you in the first slide and compare it now with this slide. Phase 0, invert sodium blockage. That is 1B. That these are the best post myocardial infarction drugs. That is in lidocaine or mexiletine. So these two drugs are the most important one which you can use in and say that, okay, this is how I have to treat and this is what I have to look in for and the drugs which I have to use. And sodium channel blockers, that is 1C. That is here, again, block phase 0. Here it is a reaction where it blocks the action of the sodium channel blocker. And the adverse drug reactions are, they are contraindicated in post myocardial infarction. The flecainide or propafenone, which you use you have to be careful, and you should not use in flecainide or propafenone in the which is contraindicated in the post-myocardial infarction. Now you saw about sodium channel blockers. You are going to see now the beta blockers. Beta blockers, here it is mainly on the sodium potassium blockade. That is class 2 drug. This is a class 2 drug. The blocks on the block phase 4. And the adverse reactions which can cause is COPD exacerbation. We have to be careful whenever we are using the beta blockers. We have to ask the patient whether he's a COPD patient, asthma patient, or he had any other allergic reactions, all these things before giving the beta blockers. And also it can cause impotence, hypoglycemia, masking. So what kind of a drugs can cause this? It can cause by propranolol, esmolol, atenolol, and metoprolol. So these are the adverse reactions of these drugs. But mind you, these are the drugs which has to be used, especially esmolol is very regularly used as an anti-arrhythmic agent. But you have to be careful when the patient is having COPD. The next one is your potassium channel blocker, which belongs to the class 3. And what happens here is prolonged phase 3, where the outward of the potassium, you see the beta blocker class 2, that is sodium potassium blockade. You see the potassium blocker, that is class 3 agent, where the outward of the potassium has been blocked. So that is very important, but at the same time, what you have to monitor whenever you're using these drugs are the TFT, LFT, pulmonary function test, and the FDPs. What is the commonest drug which we use with the potassium channel blocker? You, me, everybody are ready to use one and only drug is your amiodarone. Whenever you see any kind of an arrhythmia, you are more prone to use amiodarone. But at the same time, you have to keep in your mind what are the adverse reactions. Let it be your cardiac arrest with ventricular fibrillation. After the third shock, you start the amiodarone dose. That is 300, 150, then followed by your maintenance dose for next 18 to 24 hours. So please ensure that these are the drugs you have to mug up and keep in your brain. And then whenever there is a patient with this sort of an arrhythmia, you should not waste your time. Start off the drug so that the morbidity and the mortality of the patient comes down. The last one is your calcium channel blockers. Now, calcium channel blockers are again class 4 drugs where it acts upon block phase 0 and 4. The prolonged phase 3. What are the drugs and what are its side effects? Its side effects are edema and constipation. What are the regularly used drugs by us in emergency department is your verapamil and diltiazem. As a first line of drug, we all know that we use amiodarone. What is your second line of drug? We use either beta blockers or calcium channel blockers. That is your esmolol or verapamil or diltiazem. The third line of drugs are, we all use lidocaine, which is again anti-arrhythmic agent. Now, a bit of other adverse reactions. There is always an issue with your beta blockers or a calcium channel blockers. What can it cause? Because the beta blocker overdose or a calcium channel blocker overdose is very common in your emergency departments, because we see a lot of poisoning patients and these are regularly available for hypertensive treatments. It is available on the counter also. So you have to keep in your mind whenever these patients come with altered sensorium, you have to ask what kind of a drug they are using. If it is beta blocker or calcium channel blocker, please go with your airway, breathing, circulation, disability and give the specific drug which that is the drug which you have to use for as a drug which can counter the actions of the beta blocker and the calcium channel blocker. These both, the treatment is high dose insulin therapy. Only in this particular agent's blocking overdose, you use high dose insulin therapy, at least 1 unit per kg body weight. But at the same time, what you have to keep in your mind is the drug overdose reaction of insulin. That is hypoglycemia. Again, your beta blockers will also cause hypoglycemia. So please be vigilant. You have to take 100 ml of dextrose, give 8 to 12 units of the insulin and monitor for the potassium. If the potassium is low, please add potassium also, 20 milliequivalents, and this is called as JIC magic, glucose, insulin, potassium in case of beta blocker and calcium channel blocker overdose. Why I am telling you is the treatment is not only important. After the treatment, these sorry, these are the patients who can come back with overdose manifestations. You have to keep in your mind and treat the patients accordingly. What is the other drug you can use? Glucagon. So keep these two drugs in your emergency department ready, as you may face such a problem as the days goes forward. And potassium channel blocker, I need not say, whenever there is an hypokalemia, we have to give potassium for the patient. But the instruction should be wide and clear, bold and clear, because otherwise what will you do? You instruct your nurse, okay, please give potassium chloride 20 millicoulombs, then they'll take and give. That means that is the end of the patient. Please don't commit that mistake. Always, whichever drug you are telling in the emergency department, cross check, reassure, and then it has to be started. You have to take either 500 ml of normal saline, put up now 20 millicoulombs or 40 millicoulombs and run it over 4 or 5 hours to replace. Or if there is a central line, you can always give up to 10 millicoulombs of potassium. So this is how you have to manage the arrhythmias. You have to manage the overdose issues also. Now, sorry. What are the other antiarrhythmic agents which you commonly use? The other antiarrhythmic agents you and I, left and right, uses in the supraventricular tachycardia. What is the drug? Adenosine. We all know what is the first dose. It is 6 mg followed by 12 mg, and again it can be followed by 12 mg. If there is no response to this, then you can go with your calcium channel blocker, that is your diltiazem or verapamil. So adenosine, its mechanism of action is hyperpolarization, but at the same time the adverse reaction is dyspnea, very short half-life. Before you give the drug itself, the half-life starts. So you have to be careful that you give the drug and you flush with the immediately. Please don't forget to flush after giving adenosine drug. What is the next commonly used drug? Digoxin. How does it act? It acts by vagal stimulation or acetylcholine release, or it can also act by inhibiting sodium potassium ATPase pump. And what are the drug reactions? It can cause dizziness, mental disturbances, diarrhea, headache. And where do we use digoxin? We know that we all use in congestive cardiac failure and also with atrial fibrillation with a patient with congestive cardiac failure. It can be given in doses of either oral or in the intravenous mechanism. So what are the problems with digoxin? Again, digoxin overdose. You have to be very careful. Whenever there is an hyperkalemia with digoxin overdose, what is the drug which you should not use? Calcium gluconate. Please don't use calcium gluconate whenever there is a digoxin overdose and there is also a potassium hyperkalemia. If you give calcium for this patient, calcium gluconate, suddenly the heart will come as a standstill. That should not happen. And of course, we all know we have to give DGFAPs for the digoxin overdose. The other drug which we all use is magnesium sulfate. Magnesium sulfate is used in torsades pointes or hypomagnesemia or even hypokalemia. Whenever there is a refractory hypokalemia, we use magnesium sulfate also. And what is the mechanism of action? It slows down the SA node impulses in the myocardium and prolongs the conduction time. So that is the benefit of magnesium sulfate used in torsades pointes. But at the same time, what you have to watch for is respiratory depression, pulmonary edema, and depressed reflexes. What is the dose? You have to give 1 to 2 grams intravenous over 30 minutes. And then you can follow it by giving the infusion as mentioned. If this is how you have to manage the drugs which you are giving in the arrhythmias. I have briefly explained you how these drugs act, what are the adverse reactions, and what are the next things which you observe. And then also the overdose effects and what is the antidote which you are using. Always, please keep in your mind in your emergency department, what approach? What is your approach? Airway, breathing, circulation, disability, exposure. If you monitor these 5 things along with your management, you will never lose a patient. Okay, please keep in your mind, keep the trolley ready with the crash cart. All the drugs should be there, intubation material should be there, or amber bag should be there. And along with it, your defibrillator should also be there. And then look in for any kind of a treatable, reversible causes. Watch for the 5Hs and the 5Ts, like what I said, hypoxia or potassium, which is very, very common culprit which can cause arrhythmias. Please watch for them. And then you can give the medications accordingly, like your embolism or cardiac embolism, which will cause you myocardial infarction. Then again, there is a re-entry arrhythmias. So these are the things which you have to keep in your mind and look for and treat the causes also. Identification of rhythm is very, very important in the emergency department. Whenever you have a doubt, ask your expert, send the ECG, ask their second opinion. There is no problem at all. There is no secondary thought, because life or death, it's the patient is in front of you. You have to treat the patient. Otherwise, that will be the disaster. Look for the signs of stability. Like, what are the signs of stability? Look for whether the patient is conscious or unconscious. Patient's heart rate, blood pressure, chest pain, sweating, pallor, or hypotension. So look in for all these things. These are the signs of stability. And then plan accordingly for instability. If this approach, if you keep in your mind for an arrhythmia patient, you will never lose any patient. Identification, tachycardia, tachyarrhythmias, or bradyarrhythmias. When you're looking for tachyarrhythmias, look for the P waves, PR interval, QRS complex, T waves. Narrow complex or wide complex tachyarrhythmia. Then regular tachyarrhythmia or irregular tachyarrhythmia, or regularly irregular tachyarrhythmia. The simple example of narrow complex tachycardia is supraventricular tachycardias. Irregularly irregular is your atrial fibrillation or atrial flutter. Your simple regular tachyarrhythmia is your ventricular tachycardia, where RR interval is regular. So this simple things you have to keep in your mind. QRS complexes, whenever it is broad, it is because of ventricles and it causes ventricular tachycardia, torsades pointis, or ventricular fibrillation. And bradyarrhythmias, AV nodal blocks are the culprit commonly, and keep in your mind first degree, second degree type 1, second degree type 2, that is your Mobitz, and the third degree are the complete heart block. So these 3 things, these 4 things you have to keep in your mind. Tachyarrhythmia, bradyarrhythmia. Because in your emergency, you can see only these are the arrhythmias commonly seen in your emergency department. Now, narrow complex tachyarrhythmias. As I mentioned you can see here the irregular RR intervals. Are you seeing? I'll go in a methodical way. Are you seeing the P waves? It looks like you are seeing, but there are multiple P waves here. It is continuously triggering. The atrium is continuously triggering. So you are seeing the fibrillatory wave. You see the QRS complexes, it is narrow in nature. You see this 2 RR interval and this one, it is irregularly irregular. So that is how, when you give a bit of your ears, when you're passing through the monitor, it will say kick, 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 kick. So that itself, your monitor sound will say you whether this patient is having an arrhythmia or normal. Just listen to the monitor itself. Give the monitor, when you're watching the pulse, just listen to it also 15 seconds. Then itself you can say whether this patient is having an arrhythmia or not an arrhythmia. Now, the next important thing is, I said you, RR interval, you see, it is normal. There is no change in the RR interval. Can you see the P waves? The P waves is getting merged. You are seeing only the QRS complexes and the the T waves. So this is what you're seeing. This is the QRS complex, again narrow. Are you seeing the P wave? It is getting merged into the QRS complex. You're seeing the ST interval and the T waves. So this particular commonly seen is your supraventricular tachycardia. The next one is your flutter waves. So it looks like a sawtooth appearance. When you take an ECG and see the P wave, it will look like a flutter wave. that is called as atrial flutter. So these are the things you have to keep in your mind. Now, what is broad complex tachyarrhythmias? It is commonly seen with your QRS complexes. And as I mentioned you, QRS is nothing but your ventricular. It can be a sinus rhythm with your ventricular premature complex because the trigger is continuously happening between from the bundle of his or Purkinje fibers, which is supplying the nerve supply to the ventricles. Or it can be, you can see here, the P waves are absent. You are seeing only the QRS complexes. As I mentioned you, the bundle of his and the Purkinje fibers are overtaking the SA node and AV node. That is why you are seeing only the ventricular depolarization waves. That is your QRS complexes. And they are monomorphic QRS complexes. You are seeing the simple ventricular tachycardia. It can be polymorphic ventricular tachycardia also. The commonest thing is your torsades pointes, where you see the QRS complexes in different sizes. And lastly, cardiac arrest rhythm, that is your ventricular fibrillation. That is because of triggering of your ventricles. You are just seeing the ventricle movements. You are not seeing anything else. That ventricle movement is causing your wide complex tachycardia, which is very irregular, and that is the cause of your ventricular fibrillation. That is the reason why we all tell you, don't check for the pulse. Directly you have to give the shock. When you see a VF, don't check for pulse. Directly give the shock, start CPR. After 2 minutes, you check for the pulse, and then again if the VF is continuing, then give the next shock. This is how you have to treat a patient in the emergency department with the tachyarrhythmia, that is broad complex tachyarrhythmia. Now, bradycardia, as I mentioned you, it can be a simple sinus bradycardia. If you see a patient, if you see a gym person or a runner, his heart rate is usually low. That doesn't mean that he's having bradyarrhythmias, because you have to watch for the P wave, QRS complex, and then whether the RR interval is normal or abnormal. Then you can tell it as a bradycardia, normal sinus bradycardia. When you don't see that one and you see that there is a problem in the AV nodal block that has been replicated with your PR interval, the QRS complexes, RR interval, you have to monitor. That is your, if only the PR interval is prolonged, that means that it is type 1 block. That is your, that is mainly because of your repolarization. The stimulus is not going from the SA node to the AV node in the normal way. That is the reason why the atrial depolarization is delayed, and you see the PR prolongation. If it is more than 5 small boxes, that is more than 0.2 seconds, then you have to consider this and say that this is first degree AV block. 0.12 to 0.2 seconds is your normal PR interval. Now, the next rhythm is your second degree type 1, second degree type 2. What will happen here is, always keep in your mind, you have to count the number of P waves and the number of R waves. If it is not matching, that means that it is either type 2 or type the second degree or third degree blocks. What will happen in second degree type 1 is, it is prolongation of PR interval, keeps on prolonging and suddenly it will drop. That is what is second degree type 1. And what is second degree type 2? There is the P wave, you can see here, it is the PR interval. Wherever the PR interval is there, it looks normal. Abnormally, you can see a P wave here. But when you count the number of P waves and the R waves, it is not equal. But when PR interval is there, that is normal PR interval. This is Mobitz type 2 or second degree type 2 block. Okay. So this is the most dangerous. The type 1 and the type 2 is the most dangerous. Please check for potassium immediately. And if the potassium is low, please give potassium. Okay. The last one is your third degree block, where everything is abnormal. There is no relationship between QRS complexes and the P waves. So then that is called as third degree AV block. So this, so to tell you in short, all these things, you have to remember narrow complex tachycardia, broad complex tachycardia, and then the bradycardia, the first degree, second degree type 1, second degree type 2, and the third degree block. So, as I mentioned you, what are you seeing for signs of stability? That is, you have to monitor for the signs of shock. What are the signs of shock? Delayed capillary refill time, heart rate, blood pressure, syncopal attack. There is chest pain, that is because of a ischemic chest discomfort, altered mental status. Whenever these are there, that means that the patient is unstable, and you have to immediately become active and treat the patient according to it. And then if the patient requires a shock, you have to give the shock. Don't hesitate in giving the shock. Now, stable arrhythmia like ventricular tachycardia with pulse, atrial fibrillation which is more than old, or if there is this one, then you have to give the drugs which you can give is amiodarone, the 150 mg IV slowly, followed by you can also use beta blockers for ventricular tachycardia with pulse. And then supraventricular tachycardia, the first line of management, we all know, vagal maneuver, followed by you see whether the rhythm has changed or not, and then adenosine, 6 mg, 12 mg, 12 mg, immediately you have to flush with the normal saline. A maximum amount of adenosine is 30 mg. Don't try beyond that. If it is not reciprocating to it, then go with your calcium channel blockers, that is diltiazem, 0.25 milligrams, followed by you can give a second dose of 0.35 milligrams, or that is also not acting diltiazem, then you can use verapamil. Now, asymptomatic bradycardias, you have to always look in for the cause. There is no need of any kind of an active intervention. That is what is your symptomatic bradycardia. Now, if the patient is unstable, that is signs of hypotension, chest pain, the heart rate is very irregular, heart rate is not normal, then the patient is altered consciousness, patient is sweating, that means that you have to use your cardioversion. Please inform the patient attenders. Communication is very important in this thing. You inform what procedure you are doing. Only then you give what is required. Synchronized cardiac version, that is using the electrical. This is very, very important. The pad position is the next important thing. One is below the right clavicle, and the next one is your pad at the mid axillary line. Please don't forget, because the unilateral conduction, that is important. We all know the SA node it goes down to the Purkinje fibers and the bundle of his. So the activity is to be followed. Keep the one onto the below the right clavicle, the second pad in the mid axillary line. So biaxillary position, if the patient is in prone position or refractory shockable rhythm, you can use in biaxillary. Select appropriate joules, which is important. What kind of a rhythm it is? If it is ventricular fibrillation, we know highest amount of joules, give it off. Don't take any kind of an action. Ventricular tachycardia, start with pulse. Unstable, you can start 50 joules and then you can increase. If the patient's with pulse, always make sure you press the synchronized button. When you press the synchronized button, you can see there is a line, dotted line on the R wave. When it is happening on the dotted line on the R wave, that means that you have pressed the synchronized button and you have to deliver the shock. You have to ensure that nobody is touching, give the patient adequate analgesia, clean the part, otherwise there will be, here is a bad conductor of heat. So you have to shave and then ensure that you are giving the shock at the right way to the right patient. Then the rhythm will change, normal sinus rhythm, which you and I want to see in the emergency department. So these are the steps you have to follow when you are looking for the cardioversion. Now, unstable narrow complex tachycardias, that is your supraventricular tachycardia or atrial flutter or atrial fibrillation. These are the narrow complex which you can see. The joules used are between 70 to 120 joules. If it is not decreasing, you can always increase the joules. And then atrial fibrillation, it is again very important. You start with 120 joules and then you can keep on increasing to 200 joules, or you can look in for the highest joules which is present onto the defibrillator and give those joules which is required, or follow your AHA guidelines of 2020. Now, VT with pulse. As I mentioned, you can start with 120 joules and then you can keep on increasing to with the synchronized cardioversion as per the response of the patient. Please give a time gap. Don't do the CPR for all these patients, because I see sometimes that, okay, cardioversion is done, start CPR. No, it's just a cardioversion. You're not giving a defibrillator shock where you're stunning the heart. Here only the change in the rhythm. That is why you're using the cardioversion. If the cardioversion fails to restore your sinus rhythm, then if the patient is still unstable, then please consider for amiodarone 300 milligrams, and you can re-attempt the electrical cardioversion followed by amiodarone infusion to a maximum dose of 900 milligrams for the 24 hours. That is 1 milligram per kg per minute, not per kg, 1 milligram per minute or 6 hours, and 0.5 milligrams per minute for the next 18 hours. Please follow this. You are going to ensure the patient's safety, and also the drug utilization is in the correct way. Polymorphic ventricular tachycardia, it is because of multiple ventricular foci which is happening within the ventricles, which is resulting in the QRS complexes in varying amplitude with the axis and duration. This is commonly seen with myocardial ischemia, infarction, electrolyte imbalance. And also to tell you the patients with what overdose, which drug which commonly causes antidepressants, where the QT is prolonged and the patient will land up into polymorphic ventricular tachycardia. Torsades pointis is the most important and dangerous thing which you can see. And the QRS complexes twist around the isoelectric axis. That is what is the problem. Although it is short-lived, sometimes it is short-lived, self-terminating, please ensure what is causing it. Like what I mentioned, there is an antidepressant overdose. You monitor it, you have to give the antidote. What is the antidote? Bicarbonate. Like this, you have to keep in your mind and then treat the patient. What will happen if you don't treat the torsades pointis? Patient will progress into ventricular fibrillation. That is the most dangerous one, and the patient can die because of cardiac arrest. So what is the treatment for here? Magnesium sulfate, 1 to 2 grams or 2 to 4 grams you can give, followed by, if there is no response, you can give isoprenaline, and then if still there is no response, you can go ahead and give overdrive pacing. Okay, these are the treatment protocols you have to follow in the emergency department. Now, the next important thing is here chronic atrial fibrillation, or an atrial fibrillation which is less than 48 hours. There is a persistent atrial fibrillation. What will happen if you don't treat? The patient can go in for emboli formations, and then the stroke has been formed. So again, that is very, very dangerous. What you have to do? There are 4 important things you have to monitor. One is your risk factor modification. Second is your stroke prevention. Third is your rhythm control. Last one is your rate control. So these are the 4 arms which you have to keep in your mind when you are looking in and treating the patient with chronic atrial fibrillation. This management, what you have to see and follow it, and then you can ensure that the patient is getting the right treatment. Now, we saw the tachyarrhythmias, bradyarrhythmia. If there is a symptomatic bradyarrhythmia, please keep your atropine ready. Give 1 milligram, reassess. After 5 minutes, you can repeat the dose. What is the maximum dose? You can go up to 3 milligrams. Usually, it's given in the first degree or Mobitz type 1 block. That is what you see. Wherever in Mobitz type 2 or complete heart block, atropine is only a trial drug before you are going to start a pacemaker for the patient. If atropine is inactive, then please consider for transcutaneous pacing. Until you get your transcutaneous pacing ready, 2 drugs which are important. One is dopamine, start with 5 to 20 micrograms per kg body weight per minute, titrate the drug and then you increase the drug or decrease the drug of dopamine. The second important drug is your epinephrine, that is 2 to 10 micrograms per minute. So these are the two drugs you have to keep ready and start giving it before your pacemaker gets ready and you do the pacing of the patient. So these are the steps which you have to follow for a transcutaneous pacing. Please ensure you're keeping the pacemaker in this fashion, and only then you have to trigger the pacer. Otherwise, if you don't hold it properly, then you're not going to pace the rhythm rightly, and the patient can die because of your wrong pacing itself. Ensure that the paddles are kept in the right way, and set the pacemaker to the demand mode, and then turn on the pacing rate above the patient's intrinsic rhythm. Say the patient's rhythm is 40, then you can raise it up to 60 or 70, so that it can keep on stimulating and giving the pacer which is required for the patient. Set the MA at usually at 70, and then start pacing and increasing the MA until the pacing rate captured on the monitor. If the pacing rate is not captured at the current of 120 to 130 MA, then you may have to reposition of the above, and then again you have to look in for. This is how you can see in the monitor, and you can check and you can appropriately adjust with the MA and the rates. Once the pacing is captured, set the current at 5 to 10 MA above the threshold, whatever the threshold, say 120 MA, then you can increase up to 125, and you can watch for the pacing whether it is happening or not. So just a few examples I wanted to take you in. A patient was brought to emergency department, complaints of palpitations since 2 hours. On arrival, patient is conscious, obeying commands, stable vital signs. He has a past history of PTCA for an LAD 1 month ago. Blood test done about one day ago showed a deranged LFT and a thyroid function test. And he never used any thyroid medication. The ECG is showing this one. So what is your line of management? How will you proceed with this patient? Whether this patient is stable or unstable? As I mentioned you can see the vitals are showing is the normal. Patient is conscious and patient also had a PTCA history. That means that it is a stable tachycardia. So ventricular tachycardia with pulse and is stable. But only thing you have to see is your deranged LFT and thyroid function test. Amiodarone cannot be given in this patient. So the drug of choice will be class 1B antiarrhythmic agents, which are specifically given in your post-myocardial infarction. You can use lignocaine 100 milligrams IV, 1 to 1.5 milligrams per kg body weight. You can go up to a maximum of 3 milligrams. That is the treatment for that case. Now, the next case is 56 years old female, comes with epigastric pain intermittently since 3 days. On arrival, she is symptomatically better, but has chest discomfort. Patient is conscious oriented, stable vital signs. ECG is showing this rhythm. What is this? So the subsequent ECGs you can see here. So the patient has a complete heart block. Trifascicular heart blocks are impending complete heart block. So what is the problem here? You can see that there is a RBBB, there is a first degree AV block, then the left anterior fascicular block. All these three things are merged. So what is the best treatment for this patient? Patient has to be kept in emergency department only. Watch for the airway, breathing, circulation, disability signs. Place and transcutaneous pacer pads, standby, and shift to the cath lab. So this is what is your treatment, and permanent pacemaker should be placed, and only then the patient should be discharged. Otherwise, the patient will recome, and again the patient will have the re-problems again. Before setting in all these things, if the patient goes in for unstable, start him on atropine, starter on atropine, keep the ready with dopamine 5 to 20 micrograms, adjust the dose, or if the patient is not responding, you can go for the epinephrine. So this is what is about the treatment of antiarrhythmic agents which is commonly happening in you and me in the emergency departments. Thank you all.
Sir, that was a wonderful session, sir. You had very detailedly explained the physiology, pharmacology, assessment, identifying the rhythm and the treatment. Just to make it two quick points to the audience for the students who are attending. See, cardioversion is you are converting the rhythm. That's all. So you have to do it along with the pulse when the pulse is present. So you have to press the sync button and you have to give the shock and wait on the chest. Keep the paddles on the chest and wait until the shock is delivered. That is what you need to do in the cardioversion. And then a defibrillation shock is nothing but the maximum dosage on the machine, the defibrillator, which you give during the cardiac arrest per VF. Okay. So these are the two things we have to remember. And so there are some questions which came up in the question answer column.
Yeah, please.
The reason for the flutter and fibrillation.
As I mentioned you, these are all re-entry arrhythmias which is happening, and that is the reason because of the P waves where it happens. The we cannot say because it is the anatomical and the structural problems which are happening with the myocardial infarction, which is the common cause for all these arrhythmias, and you have to monitor this. It is the reason that the electrical impulses which are being sent from the AV node to the SA node to the AV node. So that is where you see the flutter wave, or when there is a trigger, multiple triggers before the QRS complexes, whether before the ventricles are reacting to them, this rhythm is happening, then you can see the flutter waves. If there is a continuous stimulus from the before the SA node to AV node and then it reaches down, there is a continuous trigger, then you can see the fibrillatory wave.
Yes, sir. True, sir. And there are some other questions. One person asked, doesn't the latest guidelines say adenosine 6 mg, 12 mg, and 18 mg? Actually, yes. UK and US guidelines are a little different, and you can escalate your doses of adenosine with 6 on every consecutive dosage, but usually 6, 12, and 12 is usually okay. Okay. So, and then. Sir, one more thing, I just wanted to give a quick tip on a stable and unstable arrhythmias and how to treat, sir. Is it okay with you?
Yeah, please go ahead.
Yeah, so usually when you have these three acute things, when you have acute signs of angina, acute signs of failure, and acute signs of shock. So if these three signs acute, that should be acute, need not be a chronic one, but acute ones. If they are there, that means the patient is considered unstable. So whenever you say the patient is unstable, you consider electricity for him. So if it is tachyarrhythmias, you give wide complex, you give more energy. Narrow complex, you give less energy, but you give electricity to convert them. And if it is a brady, then you go for pacing. Meanwhile, because the pacing takes time, so meanwhile you buy some time with atropine or infusions with adrenaline and dopamine. So, and if it is a stable, that means there are no acute signs, that is a stable, then you go for medicine. So for a wide complex, you go for, it's a regular PSVT, you go for adenosine, otherwise you go for amiodarone. And if it is a brady, again, you just wait and monitor and then alert your cardiologist to see what can be done, because they are stable brady arrhythmias. Okay. So I think that sums up the session, sir. Are there any other questions anyone would like to ask? If, sir, one person is asking if LFT and TSS reports are not available, the patient is known case of hypo or hyperthyroid, can we give amiodarone?
See, you have to weigh always the advantages and disadvantages for the patient. And when you are not aware of the dearrangement, that is always you are giving only the one dose. By the time you get the reports, that is your first dose of amiodarone you are going to give. And then once the report comes, you can always change the drug.
Yes, when the patient is unstable, it's what some is. It's always okay to give amiodarone as a start dose, and you can get the reports and then decide on the further doses. One person is asking, can we get the slides? Actually, this video is available on Yashoda website or Facebook. As the full live video is available for you to watch at a later time.
We can give the slides, no problem.
Yes, sir. Any other questions? Anyone would like to ask any more questions? So shall we end the session then?
Yeah, please go ahead.
Okay, so I thank you very much for this wonderful session. This was a very knowledgeable one, and you have gone into very minute details of the physiology and how the rhythm changes and how to identify them and what to treat and when to treat. So this was a wonderful educational feast, I should say, to all the things. And I would like to thank our dynamic director, sir, Dr. Pawan Gorakanti, for giving the opportunity, and Director Medical Services, Dr. Lingay, sir, for again giving the opportunity to present this topic on this webinar, and Yashoda Hospitals for providing the opportunity for all the residents, on behalf of all the residents throughout, for getting these educational sessions. I thank each and everyone for participating. Thank you very much.
Thank you. See you in the next Friday.
Thank you. Same to you, sir.